Hello, everyone, and welcome to the 2021 Care Partner Summit, Cumbre para Cuidadores through PD Health at Home. I'm Annie Wallace, Associate Director of Education at the Parkinsons Foundation, coming to you live from Tampa, Florida. The Parkinsons Foundation is dedicated to bringing the Parkinsons community virtual education and wellness programs through PD Health at Home. This month, we offer the Care Partner Summit through PD Health at Home. We feature programs designed for family care partners of people with Parkinson's, but welcome those living with Parkinson's disease as well. Today, all participants will remain muted, but are encouraged to submit any questions that you have into the Q&A section. Before we dive in, I want to talk to you just a little bit about who we are at the Parkinson's Foundation. Our mission is to make life better for people with Parkinson's disease by improving care and advancing research towards a cure. In everything we do, we build on the energy, experience, and passion of our global Parkinson's community. We have everything you need to live better with Parkinson's. I also want to take a moment to thank our generous sponsors, Accorda Therapeutics and Acadia Pharmaceuticals, who have helped make the 2021 Care Partner Summit possible. And thanks to the Light of Day Foundation, who is a generous sponsor of PD Health at Home. Today's session on sleep, cognition, and mood wraps up our PD Health at Home Care Partner Summit series. Thank you so much for joining us for the past 4 weeks as we explored mindful resilience, medication management, and other care partner related topics and conversations. Those recorded videos are available at parkinson.org/summit if you missed any or if you want to revisit them. And we hope that you'll join us for the soon to be released Care Partner Program, Building a Care Partnership, which will be discussed more at the end of the webinar. Don't forget, you can still submit a fun photo into our virtual photo booth as if we were all together in person. We'll put a link in the chat so that you can take or upload a photo and insert a branded Care Partner overlay. Remember to share this on social media. Feel free to tag the Parkinsons Foundation on all platforms at parkinson.org. Today, we are lucky to have 3 Parkinson's experts with us to talk about the intersection of 3 challenging non-motor symptoms of Parkinson's disease: sleep, cognition, and mood. Martha Ann Tudor is our mood expert today. She was a nationally recognized journalist before becoming a licensed mental health counselor. With a love of listening to individual stories, she uses a strengths-based approach to help others take control of their narratives with confidence, resilience, and a sense of humor. She says she is blown away every day by the courage and positivity of the patients and families she serves at the Augusta University Movement Disorders Program. Dr. Aleksandar Videnovic is our sleep expert for the day. He is an associate professor of neurology at Harvard Medical School, chief of the Division of Sleep Medicine at Massachusetts General Hospital, and director of their program on sleep, circadian biology, and neurodegeneration. And Dr. Joseph Quinn is today's expert on cognition. He's a neurologist at Oregon Health and Science University and the Portland VA Medical Center, specializing in cognitive disorders and movement disorders. He's director of the OHSU Parkinson's Center and director of the Northwest VA Parkinson's Disease Research, Education, and Clinical Care Center, or PADRAC. So with that, I'd love to have each of you introduce a little bit about mood, cognition, and sleep and how they interact with Parkinson's. Martha Ann, why don't you kick us off? What would you say about mood and Parkinson's, and maybe a little bit about how it can be impacted by sleep or cognitive changes?
Thank you for that introduction. I'm honored to be here today with the Parkinson Foundation and on this panel with Drs. Quinn and Videnovic to talk about mood, cognition, and sleep and their relationship in Parkinson's disease. So what is mood? Well, it's just part of being human. We all have moods depending on what's going on in our lives, depending on what's going on around us. We can have any number of different moods in a given hour, day, or week. My family had to say goodbye to a 14-year-old dog several days ago, and we've been really sad. And while everybody has sadness, times of anxiety and worry, anger, times they don't feel very motivated, those can become disorders. And we know that patients of Parkinson's are at a higher risk for developing those disorders. And disorders may be happening when those feelings come and stay and they do not lift, when they're getting in the way of daily function, when they're getting in the way of relationships, and when they're out of proportion to what's really going on in your life or around you. Research tells us that people with Parkinson's, patients with Parkinson's, that 50% of that group will experience a struggle with depression at some point in their Parkinson journey, and may even be diagnosed with depression before they're diagnosed with Parkinson's disease. Some experts believe that for Parkinson's patients with depression, that looks more like episodes rather than one continuation of symptoms. We know that 30 to 40% of Parkinson patients will struggle with anxiety at some point in their journey, and about 30% will experience apathy. And there are other mood disorders as well. In the largest study of Parkinson patients, begun 12 years ago, a longitudinal study that includes over 13,000 Parkinson patients in 5 countries, we know that taken together, depression and anxiety have the largest impact on quality of life for Parkinson patients and care partners, more than anything, including motor symptoms. And among that quality of life would be cognition and sleep. So if you have depression and anxiety, it's hard to get a good night's sleep. It's harder to think straight. It's harder to solve problems. It's harder to focus and concentrate. And in the other direction, if you have sleep disturbances or sleep disorders, that can exacerbate depression and anxiety. And we know cognitive issues from mild to severe cognitive impairment are associated with increased risk for depression. But the good news is anxiety and depression are largely treatable with a combination of medicines like antidepressants, psychotherapy like cognitive behavior therapy, and healthy lifestyle choices like exercise and sleeping right and eating right. And successful treatment of depression and anxiety leads to improved cognitive function and improved sleep. So it's important to have moods assessed early and treated if necessary. And I look forward to hearing from my panelists.
Thank you so much. Dr. Quinn, I'd love to hear from you next. How would you say that cognition in Parkinson's is a problem for folks, and how does that interplay with sleep and mood challenges?
Sure. Thanks, Annie, and thank you for the invitation. This is a wonderful program, and I appreciate the opportunity to be a part of it and to join my colleagues on the panel. Cognitive function is referring to memory function and sort of the ability to multitask and plan ahead and think sequentially and all those sorts of things. And when Dr. Parkinson first described Parkinson's disease a little over 100 years ago, he made the explicit point that thinking is not affected by Parkinson's disease. And I think that was doctors' impressions for a long period of time. But as treatment for the motor symptoms in Parkinson's have improved and people have lived longer and continued to function at a high level in terms of motor function, it's become increasingly clear to all of us, and I'm sure to all the patients and family members watching, that cognitive problems, memory problems, thinking problems, planning problems, multitasking problems become increasingly frequent as the disease advances. And the level of the problem varies from very mild problems, that are sort of at the nuisance level, up to problems that really interfere with a person's ability to function. And then we use the term dementia. The whole field has really come to appreciate that this is one of the important areas that we need to focus our research on and our efforts on to try to prevent these problems and to try to treat them when they occur. Now, the interactions with the other areas are immense. You don't need a doctor to tell you that if you don't get a good night's sleep, you think as clearly the next day. So sleep disorders really can have a profound effect on cognitive function. And the inverse also happens when there's disordered cognitive functioning. People sometimes end up with sleep disorders secondarily. And then the same is true with mood. I used this term dementia a moment ago to describe more serious cognitive impairment. And there's a term pseudo-dementia, that is a false dementia that's actually due to depression. So we don't want to misdiagnose the problem and also miss a treatable illness in terms of depression as something that can masquerade as cognitive dysfunction. So I think those are good for introductory comments, and we'll expand on this as we go. But the interactions are really profound, and I could go on and on about them, but maybe I'll just pass the baton and then we'll get to the Q&A.
Thank you, Dr. Quinn. All right, and Dr. Videnovic, what can you tell us about sleep in Parkinson's and how it may be impacted by mood or cognitive changes?
Thank you, and hello, everyone. Thank you very much for joining us at this webinar, and we certainly hope that you will find it informative and can take hopefully some tips for your daily life, and not only for lives of those with PD, but even for everyone else around them. And we all need sleep. We really need it for survival. If we didn't need sleep, evolution really would not preserve it in all species for the duration of life on this planet. Just think about it, probably a third of your life, of our lives, right, we spend sleeping. It is amazing how sometimes we talk little about sleep, right? We talk about everything what happens during the daytime, and then occasionally and sometimes very sporadically we comment on our sleep. We take it for granted, and until something goes really bad with our sleep, we don't think much about it. Or if someone doesn't point to our poor sleep and then we get treated, we don't appreciate really what a good sleep is and what miracle good sleep can do for our daily lives. So I would say that sleep problems are very prevalent in patients with Parkinson's disease, that they are frequently underappreciated by patients and caregivers, but also underdiagnosed by healthcare professionals like members of this panel, perhaps, and other colleagues who are seeing patients. We have done great improvements in recognizing how sleep is relevant for neurodegenerative disorders, including Parkinson's disease, over the past decade. But I think we have a great opportunity to utilize sleep and look at it as a potential target to improve our functioning across many disorders, including patients with Parkinson's disease. And I would say that when we talk about this intersection of mood, cognition, and sleep, really both these three domains are so bidirectionally or in many different ways kind of affected and interspersed. And certainly if someone has a lot of anxiety or poor mood, these patients, and you know by your own experience, if you wake up in the middle of the night, if something is really bothering, something is not going well in the family, their anxiety about that meeting that you need to attend the following day, you really may have a hard time falling asleep, and you will keep repetitively waking up throughout the night. Patients with depression may start waking up very early in the morning and be unable to get enough hours of sleep. And those who suffer from cognitive impairments may have some difficulties of confusion as the day winds down and before the nighttime. There may be a lot of unrest, a lot of disorientation, hallucinations who frequently accompany cognition disorders may also have a negative impact on that healthy sleep and wake cycle. And I will, in the closure of this introductory statement, just say that we cannot forget about functioning during the daytime, that function that we call alertness. It really goes hand in hand with what happens at the nighttime. So when we talk about sleep, we should think about how well organized and healthy our sleep, but also wake cycles are, this latter one from the alertness perspective. So let me pause here. I'm delighted to be here and look forward to the conversation during this hour.
Thank you so much. Well, I'd love to dive into our first question, which is one about exercise. How does exercise impact sleep, cognition, and mood? Dr. Videnovic, why don't you start us off with the sleep perspective?
Sure. Well, we all know we should exercise. I personally should do much better job, and I think that many of you could do much better. But I'm gonna, let's say, take one angle because I can talk about this for an hour. I would like to talk about the exercise as the way of our body to structure the routine and established nice control of the rest and activity cycle or awake and a sleep cycle. We know that exercise can be a very potent stimulus to our internal clock, which we all have deep in our brains, that time all physiological processes in our body. When do we go to sleep? When we wake up? When the blood pressure go up? When the insulin gets secreted, etc. And this exercise is a really very important time giver to that internal clock that sits deep in our brain to help organize and structure their sleep and wake cycles. And therefore, having a regular, well-designed exercise regimen really can help our brain structure our sleep and wake cycles in a very healthy way and a regular way. And there are many other benefits, but I'd like to hear what my other colleagues have to say about their domains, and we can expand.
Wonderful, thank you. Martha Ann, why don't you jump in next?
There's so much research about the effects of exercise on mood that, as Dr. Videnovic said, we don't even have to, it would take me more than an hour to go over it, but to say that, yes, I mean, that's the exciting thing. And if you've heard anything about Parkinson's, you've already heard exercise, exercise, exercise. While it is an important and essential part of healthy living for all of us, in the Parkinson's world, it's an effective medicine. So we know that exercise is extremely powerful in combating depression and is associated with improved depression, anxiety, resiliency, stress management, hopefulness, mindfulness. So coping mechanisms, and not just for Parkinson's patients, but also for care partners, as we realize that they are often the hidden patient under great strain themselves. And I think it's also exciting that while I know there are different types of exercise that have maybe different specific benefits for Parkinson's patients, it's really important to be moving your body so you have lots of leeway as to, you know, what you like to do. I have a couple I work with that dances in the kitchen every night. I just think it's an opportunity to be creative. We have new research telling us about the benefit of being outside if possible. You know, just the color green, the way it centers us into the here and now, and with the sounds of nature and the breeze on your face, or feeling whatever the temperature might be in your neck of the woods. So it's extremely powerful. And we also know that at any point in the Parkinson's journey, Parkinson's patients report higher qualities of life if they're exercising, whether they are, you know, at the beginning of their Parkinson journey or maybe at a more advanced part of the journey. And So it's just a very important component in overall Parkinson management.
Thank you. All right. And Dr. Quinn, what about cognition?
Great. Well, I think a lot of people, when they think about what kind of exercise you need to do to help with mental function, people think that I'm going to recommend crossword puzzles or mental exercise. And there's some merit to those things, but really physical exercise is the single most valuable, I think, intervention for promoting cognition. And we've got very good evidence from this in healthy aging studies showing that aerobic exercise can really improve cognitive function in a meaningful way. And some of those studies even show important changes in the brain tissue, not just in the short-term memory function, but showing protective functions over time. And some of that evidence is also seen in exercise studies in Parkinson's disease. So physical exercise, even though everybody thinks about mental exercise in the cognitive domain, physical exercise and particularly aerobic exercise really can make a huge difference. It's a very potent medicine. If it were a drug, it would be a bestseller. The problem is getting people to do it. And I think my advice there comes back to one of the things that Martha Ann was commenting on, which is, find something that you really enjoy, find something engaging. We have people who do have dance for Parkinson, structured dance programs that they enjoy. Boxing programs in a lot of parts of the country are very vigorous and interactive ways to do this. There's great evidence even for Tai Chi and some other activities along those lines. So as everyone is pointing out, exercise is great for all of these domains. And figuring out a way to get yourself motivated, I think, is the key, and finding something that's just right for you and maybe for your care partner.
Wonderful. With that, we'll shift to our next question. What Parkinson's medications could be impacting a decline in quality of sleep, of cognition, or of mood? And how should people with Parkinson's and their care partners approach this with their doctors? Dr. Quinn, why don't you kick us off?
Okay. Well, one of the things that go along with cognitive dysfunction that I didn't mention earlier is hallucinations. Often go hand in hand with cognitive dysfunction. And we know that the medications that boost dopamine function can promote hallucinations. So one of the things we do when we see that people are developing these sorts of problems, both cognitive dysfunction and hallucinations, is take a look at those medicines that boost dopamine. And I'll give a specific on that in a minute. But I will also emphasize that cognitive dysfunction in Parkinson's disease is not purely related to dopamine. We usually think of dopamine as the key neurotransmitter in movement problems in Parkinson's disease, but there's at least a second neurotransmitter, and the name of that is acetylcholine, and that's another brain chemical that is influenced by medications. And in the case of acetylcholine, the problem with respect to cognition is too little acetylcholine. So too much dopamine and too little acetylcholine, these two neurotransmitters, they give rise to a lot of the cognitive troubles and hallucination troubles in Parkinson's disease. So when we look at medications, we try to, if we can safely back off on some of the dopamine medications, we do. I don't want to get into too many specifics for fear of having people go back to their doctor and say, Dr. Quinn told me to do this. But we usually withdraw certain medicines that are more prone to produce hallucinations in the dopamine category. But then we also take a look at these medicines that block this other neurotransmitter. Some of those are used in Parkinson's disease, so we try to get those medicines out of the picture. The other area that I think is important to share with everybody is that there are a number of over-the-counter medications that can block acetylcholine and can worsen cognitive problems. And those medicines include Benadryl, the old-fashioned antihistamine. So Benadryl can really interfere with that aspect of brain chemistry. And if we can get those over-the-counter medications out of the picture, we can also often see some improvement. And then the other over-the-counter medications that do that are the common sleep medications. So Sominex is, and Aleksandar will probably comment on this as well. Sominex is a bad idea for sleep and cognition because of that effect. And all those painkillers that have PM at the end have components that block that chemical as well. So in brief, we take a careful look at the dopamine medicines and we try to tailor them appropriately. And then we take a look at anticholinergic medicines, including those over-the-counter medicines. Those ones we often have to ask special because they don't always show up on the med list we get from the pharmacy. So that's important for people to know about. So why don't I stop there before I go on too long?
Thank you. Dr. Videnovic, what about from the sleep perspective?
Sure. So Parkinson's medicines can be really helpful for sleep continuity. At the same time, they can negatively affect sleep. There are some medicines that we use in the management of Parkinson's disease that have a lot of alerting properties. Medicine of this type are, for example, selegiline, amantadine frequently used. And usually these medicines I try to avoid giving in the late afternoon or evening hours because they can affect sleep initiation, but also sleep maintenance. So I would save the medicines with alerting properties for earlier in the day. In terms of really dopaminergic drugs that represent the mainstream in the management of Parkinsonism, I would say that sometimes, if given late at night, especially dopamine agonists, they can cause a lot of difficulties with dreams and can predispose sometimes patients even to hallucinations, especially those with cognitive problems, although we try not to use much of dopamine agonist in this population. On the other hand, if someone has a lot of problems with overnight Parkinsonism, if they wake up in the middle of the night and then tremors reemerges, or they have a lot of painful dystonia overnight, and in another word, they have hard time turning in bed if they wake up, and then that starts to cause a lot of anxiety, but it's really the motor problem that we are dealing with. I will, in that case, recommend long-acting dopaminergic medications such as carbidopa, levodopa, long-acting formulation to be taken at the bedtime. And these can be quite beneficial for managing overnight Parkinsonism. I always, whenever I give dopaminergic medicine late in the evening, I like to follow up with those patients and ask them to give me a call in a week or 2 weeks, just to make sure that that extra dopaminergic load at night really doesn't cause a lot of problems, either in the domain of some cognitive symptoms or sleep fragmentation. As many of you know, routinely we do not administer dopaminergic drugs overnight, but there is a role for them, especially at the bedtime, in a subset of patients who may have problematic Parkinsonism throughout the night. Let me pause here and let's see and hear what Martha Ann has to say about her area.
So thank you. Because I didn't go to medical school, I hesitate to talk about certain medicines, but I will say that we do know that depression, anxiety and anger, and loss of impulse control can often be seen as side effects of very commonly prescribed Parkinson's medicines. Also, these can result from interactions between medicines. And so I think the important thing too, when it comes to talking to your doctor, would be report any difference, any side effects you notice, any side effects that your care partner notices to your movement specialist, and also make sure that you are reporting to your movement specialist all the medicine that you're on that may be prescribed by all your doctors for whatever else is maybe going on with you, so that they can quickly pick up on maybe interactions, because it could just be a difference in changing dosaging that could solve whatever problem that you're experiencing.
And then, if I may, what I'd add, which I think is relevant for this audience, antidepressants, the routinely used for management of mood disorders, can be really very helpful for good sleep.
Mm-hmm.
And in that case, some of the antidepressants are prescribed to be taken at the bedtime, usually at the doses that are much, much smaller than doses used to treat manage depression and anxiety. And this is a kind of important conversation for you to have with your providers, and because sometimes really giving antidepressant really may have nothing to do with your mood. But so I just don't want you to be taken, oh, I'm taking antidepressant, but I'm not depressed. That actually happens frequently. And also in management of sleep disorders, we frequently look at those synergies between the medications. So for example, if an antidepressant medicine, we can address both symptoms, I think that's wonderful, because we all like you to have you on the least complicated regimen possible, right? The less chemistry we put in you, the better, I think. And so this is a kind of nice synergy, I think, between the antidepressants and sleep.
Yes.
Great. All right. Well, we'll shift to our next question. How can, oh, let me make sure. Nope. Okay. Dr. Videnovic, will ask you, how does a lack of sleep over time impact cognition and mood? And then we'll check in with Martha Ann and with Dr. Quinn after.
Well, I just say that that the function and the workings and the machinery of our organism, of our body, completely changes when we fall asleep, right? We know that traditionally sleep is very important for many functions. It's important for restoration of immune function, for memory consolidation, right? If we don't have a good consolidated sleep, and particularly certain stages of sleep, the memory that we have gathered the day before may not be very, very well consolidated in our brain. So learning is so much dependent on a good consolidated night of sleep. Furthermore, a very exciting work that has emerged over the past 5 to 10 years have demonstrated that our brain changes as we fall asleep in terms of its ability to clear the toxic proteins and so-called waste that has accumulated due to intensive function of nerve cells that fire constantly as we are awake. And consolidated good night of sleep is important as it allows brain to go through these changes and through special pathways within and between brain cells to clear up these toxins and toxic proteins and waste products, the way we call it. Believe it or not, it's a strange term to use, waste, when we talk about our brain. But there is really a lot of ways that has to be cleared as we sleep at night. And you can certainly appreciate how all of these elements that I have mentioned have a favorable impact on both cognition and mood.
Mm-hmm.
Great. Dr. Quinn, Martha Ann, anything you want to add into that question?
I will just step in to say that sleep problems, disturbed sleep is something that I see in so many of the patients that I work with. And I know that recent research says a little over 75% of Parkinson's patients report sleep problems. And so I do think it's a bedrock of health. I think that without good sleep, it's kind of hard to know what's going on. I mean, when you aren't having enough sleep, you can have confusion and lack of cognition and fatigue and drowsiness that can also look like symptoms of depression. So I know in my working with patients, I am very eager to get that sleep picture right first so that we sort of know what else we're dealing with.
Courtney, I think my part on this question is well covered, but I wonder, would it be okay for me to respond to some things that are in the chat at this point?
So we can, I did see we got a lot of questions specific to Benadryl.
Yeah, that's what I was thinking. Maybe I should.
Yeah,
be
let's
okay.
dive
Yeah.
into that real quick and then we'll shift back to our questions just because
Okay,
that
so,
seems to be.
So one question was, does the concern about Benadryl apply to all allergy medicines? And it does not. The concern of Benadryl has to do with its ability to block this particular neurotransmitter that's important for cognitive function. So inhaled medicines like Flonase and ipratropium that somebody mentioned are okay. And the newer antihistamines like Claritin and Zyrtec are less of a problem with Benadryl. And then the other couple of questions are asking about should we just wholesale avoid Benadryl, or should it really be something that we should look at really when people are having symptoms of cognitive dysfunction or hallucinations and that sort of thing. Certainly when people are having symptoms, I would encourage getting rid of Benadryl and other medicines that have that what we call anticholinergic property. I don't think I would exclude those medicines outright altogether, but if there's any indication of early cognitive dysfunction, that's when I would get it out of the way. So Courtney, thank you for giving me the opportunity to answer those because they were a cluster of them. Yeah.
Yes, all right, so let's shift to our next question. How can cognitive changes and a lack of sleep impact the driving of the person with Parkinson's? We know this is a huge concern, especially for many care partners who have to, have this really challenging conversation with their loved ones with Parkinson's. Dr. Quinn, you want to jump in first?
Sure. Driving safety is a real serious issue for somebody with cognitive dysfunction. Mild cognitive troubles with multitasking and very mild impairments, I don't think we should consider a contraindication to driving. And there's some nice research by Dr. Uch in Iowa looking at driving safety in Parkinson's, and people with mild troubles seem to do okay. But when the problems get more severe, we really do need to look at driving safety and consider driving cessation. It's hard for us to make for us physicians to make a clear recommendation just based on what we're seeing in the office, unless things are really quite extreme. So what we do in questionable situations where there's a little bit of dysfunction or a moderate amount of dysfunction, we're trying to decide whether it's time to stop driving or not, is turn to our allied health professionals, occupational therapists, some of whom are specifically trained in driving evaluations. And then there are also some driving schools that we can look at. But, I think my personal feeling is, when in doubt, they should probably stop driving. Safety has to come first, but we try to get as much objective information as we can to make that call.
Great. And then what about from the sleep side, Dr. Videnovic?
Well, from the sleep side, obviously, we need to think about the drowsy driving. That's the major issue. And medications that we traditionally use that are mainstream in terms of treatment Parkinson's disease, all dopaminergic medicines can make patients very sleepy. And dopamine agonists as a class of drugs, ropinirole and pramipexole, these medications have the highest propensity for making patients sleepy while they are driving, or just simply sleepy during the daytime. That is really extremely important to recognize. And that's where I would say caregivers, spouses are really very important to interview, because patients may not appreciate the degree of their daytime sleepiness very frequently. And regularly, I see patients telling me, oh, no, everything is fine. And then I see the spouse waving here. Oh, absolutely not. You know, you don't even appreciate how frequently you fall asleep. And then the challenge is that there is a special type of sleepiness that patients with Parkinson's disease may be exposed to, and that's a rapid onset sleep. We call that sleep attack or sudden onset sleep, where patients can transition from full wakefulness to full sleep within 30 to 60 seconds. And when I discuss this with my patients, right, when I tell them that we either need to modify the medication regimen or that in this current scenario, until we sort it out, there is no driving until we sort this issue of daytime sleepiness, I frequently hear this answer, oh, don't worry, doc, you know, my window is always open, I blast the music and I have a coffee next to me and I always sip the coffee, and I tell them that's all wonderful, you really should not continue to do this because we cannot drive anymore. None of these things that you think may be beneficial are bulletproof and will not prevent you from falling asleep at the wheel and hurting yourself or someone else. So drowsy driving, very important aspect in the care of patients with Parkinson's disease. And pretty much every single visit that I have with a patient with this disorder, I have a discussion about their sleepiness and their driving capacity. That's what I would say about sleep and driving.
Wonderful. I see a really great comment in the chat about spatial orientation being a challenge for driving. That's one I don't always think about. So I wanted to mention that out loud to everyone in case you missed it in the chat. Before we shift, Martha Ann, I wanted to check in. Do you have anything on your mind around sort of the dynamic of bringing up driving concerns for care partners? Because I know this can get really heated.
I'm just so glad you asked that. I see it all the time. And yes, so I'd like just to say, you know, to recognize that this can be traumatic for a Parkinson's patient, the giving up of driving, the loss of independence and power and control. It can just be devastating. For some people, it's all right, but for some, it's absolutely traumatic. And I do think that the driving schools that I believe Dr. Quinn mentioned are a nice sort of objective assessor. And so it maybe lets that spouse or care partner off the hook, so to speak, because I've seen patients, that think, well, they're just being negative or they're just being critical or something. But to have that objective opinion a lot of times helps a lot. But just to have compassion and understanding, to understand what this person's going through and the magnitude of that for them can really help a lot.
Thank you. So our last question that we have prepared, and then we'll shift and answer some questions from attendees. I'm excited we'll have time to do that. I wasn't sure if we would. But our question is, which mood, cognition, and sleep challenges do you three see as most challenging for the care partners that you work with? Mm-hmm. Martha Ann, why don't you start us off?
Well, two come to mind. One would be anger. I think that, hurtful things can be said when, say, if a patient is experiencing anger and they lash out. And of course, the care partner's usually that one that's closest in and going to get the brunt. Hurtful things can be said. The other thing that I think is, I see can be maybe the most frustrating for care partners is apathy. It can be extremely frustrating to watch someone that you care about just not do what they, will help them. Get up and exercise, get out, take their meds on time, stay connected. So that can be extremely frustrating. Again, I think to be able to step back, realize this is part of the disease. The person isn't simply trying to be difficult. They're not being lazy. They don't just need to snap out of it. And the more the care partner is able to get away, have respite for themselves, have their own support system, do things that are restorative to them, the better they're off, the more they're going to be able to not put the behavior on the face of the patient and be able to see it for the disease, and be able to keep perspective, maybe even a sense of humor, and not take it personally, so to speak. And while we don't really have a lot of great treatment for apathy, which, by the way, is not depression, it's not fatigue, it's just sort of a lack of motivation. And while we don't really have a lot of great treatment for that, there's not a pill you can take. It can help to have a structured life, have a structured schedule, for the patient to take those meds, get out and exercise, stay connected, even if they don't feel like it. But I have found those to be really associated with caregiver burnout and caregiver stress more than some others.
Thank you. Dr. Quinn.
Well, Martha Ann stole one of my answers. I was going to say apathy was was one of the hardest things to deal with for all the same reasons that she so nicely outlined. And that's there is a class of medicines that boost that neurotransmitter acetylcholine that some studies show a little bit of an increase, improvement in apathy, but in my experience, it's a minority of the patients. It's a subpopulation. Usually it's a very, very hard symptom to treat. The other aspect of cognitive dysfunction, I think, is very distressing to the families and very difficult to treat, is impulsivity, the inclination to just do things impulsively. There is a syndrome, and it's coming up in the chat box a little bit. There is a syndrome that's called an impulse control disorder, which is a very discrete syndrome in which people engage in compulsive gambling, spending, eating, and compulsive sexual behaviors. And it's an important syndrome for people to know about, because it can actually be significantly promoted by some of the Parkinson's medications. When I was a young neurologist, we didn't know that this existed, and I don't know how many people I gave this to and never heard about it. So it's really become important for us to educate family members about this so they can report it to us and we can make adjustments as they arise. But then even beyond that very discrete syndrome, which I will also emphasize affects a minority of people with Parkinson's, when people have cognitive impairment, they often lose some impulse control in a sort of a different way. And there's not a pill to take care of that. And it really is a matter of modifying the environment and also gaining an understanding, as Martha Ann was saying, with apathy, that it is part of the disease. It's not a willful behavior on the part of the patients. So apathy and impulsivity, I think, are the two sort of extremes of behavior, and also the ones that are most vexing for families and for docs.
Before we shift, we did have one very specific question that I'm particularly interested related to the impulse controls. Someone asked about whether these addictive behaviors could possibly be an early sign of Parkinson's, or if they're only ever tied to the medications.
Most of the time it is tied to the medication. There is some good research suggesting that some of this will happen rarely in people who are not medicated, but it seems to be mostly tied to the medications and to particular types of medications.
Great, thank you. All right, so Dr. Videnovic, what about from the sleep perspective?
Well, from the sleep perspective, I'd say we all need good night's sleep, right? So I think that the biggest challenge is for our bed partners and caregivers, that they may not get a good night of sleep if her or his loved one is not having a good night of sleep, right? And we always, either at the beginning or maybe for sure at the end of a visit, turn out to caregiver and spouse and ask them, and how are you doing? Because, and sleep is here very important, right? I'd say that caregivers really need to take a step back and think, well, how am I sleeping in the midst of this fights that we have with this disease? And sometimes bed partners can be injured, and they can be injured specifically due to this specific sleep disorder called REM sleep behavior disorder, in which patients have a lot of bad dreams, in which they are fighting against the aggressor. And in the midst of the dream, they can move and do all kinds of things, including punching and kicking and yelling and thinking that the bed partner may be that aggressor or intruder. So it's important also to recognize appropriately some sleep disorders and to treat them, because some of these disorders pose risk for injuries, not only to patients themselves, but also to those that they share bed with. So I'll leave it at this.
Thank you. Well, we do have time for a couple of questions. So I've picked out some that I think most folks will be interested in. We won't get a chance to answer all of your questions, but we do always recommend that if your question doesn't get answered, the best place to go is our Parkinson's Foundation helpline. We'll put the number and the email that you can actually send your question to into the chat. We got several questions about bladder control overnight, which was interesting. Wanted to see if this is related in any way to quality of sleep, if there are any ties to cognition or even mood in these challenges around bladder control.
Well, we know, I can start with this one. We know that patients with Parkinson's disease have a autonomic dysfunction, which is a problem that leads to problems with blood pressure regulation, urination, etc. And getting up at night for a patient with Parkinson's disease may be very challenging because it makes them prone to the risk for falls is really increased substantially. That's the major danger, at least in my mind. I would like to say that, yes, when we ask our patients, they frequently say, oh, my sleep is interrupted. I need to go to urinate. So that really makes my sleep problematic. Well, there is a really truth in that, but also it may be vice versa. Very frequently, if sleep is not consolidated, just by waking in the middle of the night, we can feel that bladder fullness and say, oh, I need to go to use the bathroom. So treating sleep and improving sleep continuity may also result in substantial reduction in this overnight urination trips that patients need to make. And that's a very important, I think, frequently overlooked message that we really need to deliver to our patients and their caregivers. So I'll pause here. This is just one particular element that I wanted to emphasize about this question.
All right, anything to add from the other perspectives? If not, we'll move to our next question. All right, we got a really great question about sex and intimacy, which I know can be uncomfortable to discuss, but I think it's really important. It's an important part of quality of life for a lot of people. So I wanted to see if any of you would be up for talking a little bit about how intimacy can be affected in Parkinson's related to sleep changes, maybe where people are actually sleeping, but also cognitive changes and mood changes.
All right, so let me start, and I will say that frequently patients and loved ones have to sleep in a different bed, and that happens really because of unresolved sleep issues. So one incentive, if for no other reason, maybe just to make that intimacy stronger and come back again, is really to address these sleep problems that are occurring during the nighttime. So this is a kind of more environmental issue that underlies sexual activity of our patients and their loved ones. And I'm sure there are other aspects as well that are relevant to mood, relevant to underlying autonomic dysfunction, appropriate diagnosis of certain sexual problems. Some of this really may be manifestation of age. So we just want to make sure that physiology is working. I think mood is important, but let me see what my colleagues have to add or correct me.
Thank you for what you said. You know, I have patients and care partners that I have had the honor of working with, where you see the lack of interest in intimacy on both sides. Sometimes it's the patient, but sometimes it's the care partner. And I know that there are sex therapists, which is where I send my patients and care partners. One of the great things about Zoom, like we are today, is if you live somewhere where there's not someone like that located, because there aren't that many everywhere, you're not in a major city, you know, you can find telemental health and telesessions with sex therapists now, and you have opportunities for expertise that otherwise might have not been convenient or available. But I think it's an opportunity for creativity, for honesty, for communication. And I know that I have had, I just can say there's hope, because I have had patients and care partners who've had wonderful experiences in this area when they thought, you know, it was all but lost. So it's an encouraging area, and there is hope to be had there.
All right. Well, before we wrap up, is there anything that any of the three of you think we missed that's worth throwing in there, or anything that we talked about that you think is worth highlighting before we close today?
One thing I noticed in the chat, Annie, is a lot of questions about where can I find a counselor? How can I find a counselor? And so I would just say to start with maybe your movement disorders office, disorder specialist's office, and ask them if who they recommend in your community, if they're associated with a medical center where they may have a counseling department. I know that psychiatrists are important to be kind of part of the picture because of the potential interaction with Parkinson meds, but a lot of the counseling does not have to be done by a psychiatrist. That can be a licensed clinical social worker, a licensed professional counselor, a licensed marriage and family therapist, psychologist, on and on. So that's where I would start. Another might be your local Parkinson support group. I think resource sharing is a big strength of support groups. And that would be, that's where I would start to see where maybe others living with Parkinson's have found help and resource in your area.
All right. Well, I want to just say thank you to the three of you, our wonderful panelists. Thank you to everyone who attended today live and sent in your questions. And thank you to those of you who will join us after the fact. If you'd like to see more of these discussions from our experts, make sure that you're registered for the Parkinson's Foundation Care Partner Program, Building a Care Partnership. This program will offer online courses that will be available starting on June 1st in both English, and then after a few weeks, we'll have them in Spanish, and we'll grow indefinitely, offering more and more ways for care partners to learn, grow, and connect with one another. I'm excited to share with you all that the 3 courses that will launch on June 1st feature the 3 experts you saw today, diving a little deeper into each of their areas of expertise: sleep, cognition, and mood. So the link to register for this course will be in the follow-up email for today's session. I want to thank our sponsors one more time: Acadia Pharmaceuticals, Accorda Therapeutics, and the Light of Day Foundation. And I want to highlight again that our Care to Talk cards, which we used in last week's Wellness Wednesday Town Hall and are talked about a lot in the Care Partner courses, are available at parkinson.org/care-to-talk. And finally, as I said, thank you guys for joining us today. We believe strongly that care partners are an important part of the healthcare team, and that there is so much you can do to help care for your loved ones' physical and mental health needs. I hope that you all have felt inspired and empowered by all of our speakers throughout the 2021 Care Partner Summit, Cumbre para Cuidadores, takeover of PD Health at Home. We at the Parkinson's Foundation are so grateful that you've joined us. Thank you, and we will see you next time.